Hello and welcome. Today we're diving into a relatively rare, but potentially life-threatening condition of the stomach, gastric volvulus. Gastric volvulus occurs when the stomach abnormally rotates more than 180 degrees on itself. The causes can be categorized as primary or secondary. Primary volvulus is due to laxity or absence of the stomach-supporting ligaments like the gastrophrenic, gastrosplenic, and gastrocolic ligaments. Secondary volvulus arises from problems with adjacent organs or tissues pulling or displacing the stomach. This can be due to diaphragmatic hernias, paresophageal hernias, adhesions from previous surgeries, tumors, or even enlarged spleen. The pathophysiology of gastric volvulus is complex, depending on the degree and duration of the rotation. As the stomach twists, it obstructs the flow of food and liquids. This obstruction leads to distension of the stomach. If the volvulus is severe enough, it can compromise the blood supply to the stomach wall, leading to ischemia, necrosis, perforation, and peritonitis. The impaired venous drainage can also lead to congestion of the stomach wall. Gastric volvulus is a rare condition, accounting for less than 1% of all gastric abnormalities. It can occur in all age groups, but there are two peak age groups: infancy, where it's often associated with congenital diaphragmatic hernias, and older adults, typically over 50, where it's more often related to acquired conditions. There's no known significant gender predisposition. The classic presentation of acute gastric volvulus is Borchart's triad, which includes sudden onset of severe epigastric pain, retching without vomiting, and inability to pass a nasogastric tube. However, this triad isn't always present. Other symptoms can include abdominal distension, dysphagia, shortness of breath due to pressure on the diaphragm, and chest pain. Chronic volvulus may present with intermittent, less severe symptoms like vague abdominal discomfort, early satiety, and nausea. Diagnosis is often challenging due to the non-specific symptoms. An upper gastrointestinal series or barium swallow is a valuable diagnostic tool. It can visualize the abnormal position of the stomach and the obstruction. A CT scan of the abdomen and pelvis can also be helpful, particularly in identifying the cause of the volvulus, such as a hernia or tumor. Endoscopy can be used but might be difficult to perform, and caution should be taken to avoid perforation if significant distension is present. Gastric volvulus can be classified based on the axis of rotation. The most common type is organoaxial volvulus, where the stomach rotates along its long axis, from the cardia to the pylorus. Mesenteroaxial volvulus is when the stomach rotates around its short axis, from the lesser to the greater curvature. A third, less common type, is a combined volvulus involving both axes. Treatment depends on the severity and chronicity of the volvulus. Acute gastric volvulus is a surgical emergency. Initial management involves stabilizing the patient, placing a nasogastric tube if possible to decompress the stomach, and providing intravenous fluids and antibiotics. Definitive treatment usually requires surgery, either open or laparoscopic. The aim of surgery is to reduce the volvulus, correct any underlying anatomical defects, and prevent recurrence, often by performing a gastropexy, which secures the stomach to the abdominal wall. For chronic, intermittent volvulus, elective surgery may be considered to prevent acute episodes. Unfortunately, there's no specific way to prevent primary gastric volvulus due to congenital ligamentous laxity. However, addressing underlying conditions like diaphragmatic hernias or large hiatal hernias can help prevent secondary volvulus. Maintaining a healthy weight and avoiding activities that significantly increase intra-abdominal pressure may also be beneficial. The prognosis for gastric volvulus depends on the promptness of diagnosis and treatment. Early diagnosis and surgical intervention lead to a good prognosis. However, delayed diagnosis can result in serious complications like gastric necrosis, perforation, and death. Recent research is focusing on improving diagnostic imaging techniques and refining minimally invasive surgical approaches to reduce morbidity and improve outcomes.